Hello, everyone, and thank you for joining another Outcomes for Me Ask the Expert webinar. Today, we are delighted to close out Triple Negative Breast Cancer Awareness Month by bringing you a top expert in TNBC disease to answer questions that we've gathered directly from our community. If you're joining us for the first time, my name is Suzanne Garner. I am Director of Marketing and Community at Outcomes for Me. I'm also a stage 2 breast cancer survivor. I came to work for this company after my own diagnosis and finding this tool and it being such a source of evidence-based information for me. This company exists because the people working here are on a mission to help educate and empower patients to feel confident and informed and advocate for themselves in the most effective way possible with their medical teams. For today's webinar, I am honored to introduce Dr. Tiffany Traina. I'm going to be reading her bio because I did not memorize it, and she has done quite a bit. She is a distinguished oncologist at Memorial Sloan Kettering Cancer Center and researcher, and cancer researcher, specializing in breast medicine and leading the Triple Negative Breast Cancer Clinical Research Program. Dr. Traina's innovative work, especially in TNBC, aligns perfectly with our mission to be bringing you experts to answer your questions. Her leadership roles in several ASCO committees, that's a top oncology meeting and organization, including prestigious awards from the Susan G. Komen Breast Cancer Foundation and the Triple Negative Breast Cancer Foundation, make her insights invaluable, and we are so lucky to have her today. So welcome, Dr. Traina. I would love if you could introduce yourself to our community and maybe fill us in on anything that I just missed there.
Oh my gosh, thank you so much for the invitation to be here. And I'm so grateful to spend this time with you, with your audience, and really for the work that you do. It's a real privilege to care for patients with triple negative breast cancer and really focus my energies on education, awareness, research, trying to understand the biology of this cancer better and really develop newer therapeutics that we continue to see improved outcomes for our patients, both with early stage disease and advanced disease. So thank you for all that you do, and thanks to everybody for joining in today.
Well, we are very excited for this. So I have received quite a few questions that we've been gathering the last few weeks from our community. So if it's okay with you, I'm going to just jump right in. And I think I have the perfect high-level one to start us off. And this patient asked, what exactly is triple negative breast cancer and how does it differ from other types of breast cancer?
Super question. So if you imagine a decade or two ago, the simplest way that we had to define breast cancer was really just based on its hormonal drive. And the majority of breast cancers are driven by estrogen and progesterone. We later recognized another important biologic driver, which was the protein HER2. And so when patients had tumors that tested negative for hormone receptors and negative for HER2, doctors simply called that triple negative breast cancer because they were ER/PR negative and HER2 negative. And I think a big limitation of that terminology is that it never really described what was unique about the breast cancer. It just told you what it wasn't, that we knew endocrine therapies, anti-estrogen therapies would not be of benefit. We knew that the therapies developed for HER2 positive breast cancer, as it was defined back then, really wouldn't be of benefit. And so triple negative breast cancer just simply means hormone receptor negative, HER2 negative. But we really need to do a better job at describing what's the subtype of the triple negative breast cancer? What are some of the important biomarkers? Because that describes the biology, and then that will help you and your doctors understand what the best treatments are.
Okay, thank you. That's really helpful.
Sure.
Okay, this is a good one. I think I have felt this deeply, just in understanding our prognosis. And so this patient asked, what are the current statistics on the prognosis for TNBC? My oncologist said that most of the statistics I can find online are outdated and that my prognosis is probably much better than this. Do you agree?
So I know wonderful question. Yeah. Yes, right. It's a wonderful question. And I think I would take a huge step back at a way to address that and say the internet is a great place with a lot of information, but sometimes it's challenging to put the information that you find there into context and to understand how much does that really apply to my own individual situation. So I would just couch what you do find out there really needs some professional guidance to help put that into context. Early stage triple negative breast cancer, whether you hear your cancer is stage 1, 2, or 3, is curable breast cancer. The goal of therapy there is that with surgery, with chemotherapy, with immunotherapy, if that applies, with potentially radiation, with all of that together, we hope to keep that breast cancer away for life and minimize any risk of recurrence and cure women of breast cancer. The risk of recurrence varies depending on a bunch of different things, size of tumor, lymph nodes involved. But I will say that compared to what you'll find in the literature from 5 years ago, 10 years ago, we now have such improved therapeutics, a strategy for immunotherapy, strategy for neoadjuvant therapy, where you get your chemo and your immunotherapy before surgery. All of that has enabled us to improve overall survival. So if you Google for stage 2 triple negative breast cancer, what you find with long-term follow-up is not going to reflect our most current hot off the presses therapies. And similarly with metastatic breast cancer, there, unfortunately, with our therapies today, we can't say that we can make the cancer go away forever, but we have done such a better job. And I see innovations month over month and year over year that has improved the ability for women to live longer with high quality of life, with controlling the breast cancer while it's managed with new innovative therapies. And so I think these are really frank, honest conversations to have with your doctor, your care team, to really ask what is the goal and expectation of the treatment that you're recommending, right? And really be sure you're talking about what your values and priorities are with your care team so that your treatment plan can really be very personalized for what's most important to you.
Thank you for that. I mean, that is really encouraging, and it sounds like more than ever before, there are so many tools in the toolbox, as they say, to help with this type of cancer. Okay, so you touched a little bit about the specifics of everyone's disease. This question is, how does the grade of TNBC affect its aggressiveness and my treatment options? Is TNBC always grade 3?
I love this question because it really gets at what I mentioned in the very beginning, that triple negative breast cancer is very heterogeneous. It's not just one disease. So just a moment on grading. Tumor grading is on a scale of 1 to 3. And I would think about it as a spectrum that allows the pathologist to tell us how closely does this cancer cell look like the normal breast cell of origin, right? The closest that cancer cell looks to a normal, well-behaved breast cell, that would be more like a grade 1 cancer. And grade 3 cancers, or poorly differentiated cancers, have really learned how to misbehave, right? They don't really resemble the pure original breast cancer cell or the breast cell that they derived from. So I would say that the majority of invasive breast cancers that we see end up being grade 3 cancers. And the majority of triple negative breast cancers have that poor differentiation, but not all of them. And there are some unique subtypes of triple negative breast cancer that can have grade 2, grade 1 biology, may come up as moderately differentiated on a path report. You may see terminology in the path report that calls this an adenocystic carcinoma, right? So those test ER, PR, and HER2 negative, they would test as triple negative, and yet their biology is very indolent, very quiet, and grade 2. So this is the nuance that you really do want to look at all of that language in the pathology report, and don't be shy about asking your doctors what's the significance of that. Yet if you're seeing grade 3, know that that is the most typical grading that we'll find with an invasive cancer and a triple negative breast cancer.
Okay, thank you.
I hope that helps.
That was an awesome explanation of grade, and I do think that there's an assumption when you read or even talk patients amongst themselves about TNBC disease, that it's assumed that it's always that most aggressive grade 3 type, right? And they're not all the same. So,
right.
Speaking of us not all being the same, the next question, what research is being done on TNBC for people of West African descent? Are there clinical trials being done for this population?
So this is a great opportunity to mention that triple negative breast cancer in general, we tend to see occur at an earlier age in women. So compared to hormone receptor positive breast cancer, which is more typically postmenopausal women in their 60s, we see triple negative breast cancer occurring in women in their 30s and their 40s, and sometimes even younger than that. One of the other characteristics we see is that triple negative breast cancer seems to occur more frequently in women of African American descent, and even Hispanic women. One of the big gaps and opportunities is to be sure that women of this background are included in our clinical trials, that are really advocating for representation in the studies that are being done. So there are investigators out there in the breast cancer community that are very much looking at the differences in breast cancer occurrence based on race, ethnicity, socioeconomic status, access to care. There are so many variables in what explains both biology and outcomes to therapy. So while there may not be a therapeutic intervention study specifically for a certain ethnic group, there is a lot of work being done to try to understand this better. And I would say we have a duty to be sure we're educating about clinical trials, dispel some of the myths that are out there about studies, and be sure that our broad population of patients is well represented in our studies, our clinical trials, so that we know if those great advances that we're finding are widely translated to our population of patients.
Yes, that is so important. I know that clinical trials aren't always brought up in clinic with your doctor. So I participated in a clinical trial. It was a great experience for me. I really try and encourage other patients every chance I get to at least explore it. So a quick plug for our app, but for anybody listening that might be interested in that, if you want to start looking into trials, we do have a full list of all of the current breast cancer clinical trials. And when you're onboarded onto our app and you fill out the diagnostic questionnaire, it will show you trials that are relevant to your specific disease type. So it's really hard to just go to there's a website called NCT that has all of the trials, but it's super hard as a patient without a medical background to understand if one's relevant to you or not. So if you're interested in it, I would encourage you to check out our service in our app. But thank you for that answer. And the diversity part is so important. And I hope that we can do better. Okay. So then our next set of questions are around kind of research and clinical trials that I gathered. So first, treatment options. So what right now are the standard treatment options for TNBC? And if there are multiple paths, so I suspect this patient is kind of being given a choice. You could do this or you could do that. How are they decided?
Okay, this is a wonderful one to unpack. So there are a few different things. I'd like to break this down a little bit. So let's talk about standard of care therapy for early stage triple negative breast cancer to begin with. So this is stage 1, 2, 3. And I would say for me, it's actually even more important to be detailed about not just the stage, but understand and know the tumor size within the breast based on imaging, and the lymph node status. Because as we think about our therapeutic approach for standard therapies, it depends upon tumor size and nodal status. For women who have a tumor that's teeny tiny, less than 2 centimeters on imaging, with no apparent lymph nodes on exam or on imaging, The standard today would be to go to upfront surgery, get that tumor out of the breast, sample those lymph nodes, look under the microscope, get a real defined size and nodal status, but remove the visible disease. And then consider systemic chemotherapy afterwards. And which chemotherapy is used, there are some different options, will largely depend on the size of the tumor, a woman's own other medical conditions that might make one chemotherapy regimen a little bit more toxic and worrisome than an alternative. But generally, women who have a triple negative breast cancer, 5 millimeters or bigger, even with negative nodes, will be recommended chemotherapy. And you may hear different regimens like TC, which is taxotere and Cytoxan for 4 or 6 cycles, or a very standard regimen of ACT, which takes about 4 months to complete. The nuance of how to choose one or over another is really a detailed conversation with your care team. You want to ask questions like, what's the incremental benefit of doing choice A over choice B, right? Is one more curative than another? Is one more likely to keep the breast cancer away than the other? And then to balance that question is asking, what are the differences in the side effects, right? There are some differences in risks of hair loss. There are some differences in heart toxicity. There are some differences in nerve damage. And so that's where your doctor can really help personalize, maybe the risk of one is going to be greater than the other and help you with some of that choice. I also think at every decision point, it's reasonable to ask, are there clinical trials in this space that I should be considering? I mean, it's really important to try to do that research yourself, but it's overwhelming. And to your point, I'm so glad the app has a way to filter this and make that easier. But it's a good question to put towards your care team. There may not be a trial in that moment, in that setting, but they know you're really interested in pushing the envelope and you want them to be thinking this way. And you want your care team to even reach out more broadly and maybe reach out to academic centers that are nearby in your neighborhood so that you have available to you all the possible resources that are there. Again, thinking about early stage triple negative breast cancer, if the tumor size is larger than 2 centimeters, or if there's a suggestion that lymph nodes are involved on imaging or that you can feel on exam, then this is a place where we want to slow the brakes on surgery and instead start with chemotherapy and immunotherapy. So right now, this is really exciting. This is the only place in breast cancer where immunotherapy is FDA approved. It is in early stage triple negative breast cancer for women who have a tumor larger than 2 centimeters or involved lymph nodes. And by moving up your chemotherapy regimen plus immunotherapy before going to surgery, we have not only seen tumors just shrink down considerably and sometimes even disappear altogether, but we've seen breast cancer survival improved for those women. And based on the results that you get at surgery, whether there's residual disease there or whether it's all gone, it helps your care team refine your treatment plan even better. So immunotherapy is continued to finish out a year, but if there was still some residual disease there, we now know that a chemotherapy pill for another 6 months can help improve survival for those women. Or if you are known to have a genetic predisposition to breast cancer, a BRCA1 or BRCA2 mutation, we know that using the pill called olaparib for those women for a year after surgery also helped improve survival. So the standard of care today is really quite innovative, really pushing the envelope. It's where we're using immunotherapy in early stage breast cancer. Super, super exciting. And so that would be standard of care today for early stage disease.
It's so encouraging and just as you said, innovative. I mean, this is precision medicine, right? Just following each individual patient, and there are so many therapies now to help. So that is really encouraging. I did get a question live while you were speaking that I think is really relevant before we move to treatments in metastatic disease. So she wanted to know what is the optimal follow-up look like? And she's specifically asking about scans. So should she be getting scans as an early stage patient for the first 3 to 5 years?
Wonderful question. We do get this a lot, and unfortunately, so regular follow-up is really checking in with your doctor about every 6 months for the first 3 to 5 years. At that point, doing physical exams, having basic blood work done is really standard. It's also an opportunity to make sure that we're keeping track of breast imaging in terms of future screening. So whether that entails mammogram alone or mammo plus something else like ultrasound or MRI. It involves for postmenopausal women checking bone densities every 2 years, because there's an opportunity here in postmenopausal women who receive a bone strengthening medicine. There's actually better breast cancer survival. So even though it doesn't seem so tightly correlated and not something you'd think your breast oncologist should be worrying about, you do want to think about bone health because there's a breast cancer benefit there. We're also helping with sorting out colorectal cancer screening. So it's an opportunity to think about wellness in general, diet, exercise counseling, all of the above. As much as we would like to think that additional scans would be helpful, CAT scans, PET scans, and the like, there's really no data that doing those scans has helped to catch metastatic breast cancer early. And that's the drive for imaging in mammography and MRIs. It's all the idea that if you catch something early and intervene, you can cure these women of breast cancer. That has not been borne out, unfortunately, with CAT scans and PET scans. But there is an area that I want you to think about and have on your radar because it's where the research is really going. There's this technology of looking for circulating tumor DNA in the bloodstream before you can ever detect that a lump is anywhere or that there's an abnormality on a scan. There can be an early signal that something's brewing by doing this circulating tumor DNA testing. It has not yet been proven in clinical trials that if you follow circulating tumor DNA, find some and intervene with a therapy, that it changes outcome yet. But those are the trials that are being designed right now. So if you're interested in this kind of heightened surveillance in a high-risk situation, you want to explore who's doing those circulating tumor DNA studies and can you do it in the context of a trial. The idea there is that you catch something before it's ever apparent on a scan.
Okay. So that's interesting. So that's the ctDNA surveillance might not be something that is offered in every clinic, but if a patient is really interested in it, it sounds like there are some clinical trials out there where they would be routinely getting that test.
Exactly.
Okay. Thank you. Yes, then I would love to move on to the current therapies for metastatic TNBC.
Absolutely. So in contrast to early stage triple negative breast cancer, the approach to metastatic triple negative breast cancer is very much driven by certain biomarkers. So one question you absolutely want to have an answer to is hereditary genetic testing and whether you carry a mutation in BRCA1 or BRCA2. This obviously has implications for risk of developing a breast cancer and has implications for family, but it also is a biomarker today that allows your doctors to choose therapies like PARP inhibitors, medicines like olaparib or talazoparib, that are FDA approved only in women who have germline BRCA1 or BRCA2 mutations. So question number one, do I have a BRCA1 or 2 mutation? The other important biomarker that is standard of care that you need to know in metastatic triple negative breast cancer is whether the tumor tests positive for something called PD-L1. So PD-L1 is a predictive marker as to whether immunotherapy will work or not in metastatic triple negative breast cancer. And for tumors that are PD-L1 positive, the first choice as first-line therapy for metastatic disease would be using immunotherapy called pembrolizumab with chemotherapy. And that chemotherapy could either be a taxane or commonly platinum-based chemotherapy like carboplatin with gemcitabine. So if PD-L1 positive tumor, you want to be leading with immunotherapy plus chemo. And that's because long-term outcomes are better. it is superior to get that immunotherapy. If women's tumors, I should say, lack PD-L1, then the first line chemotherapy standard of care is generally either a taxane or a platinum, or sometimes there's even a place for the chemotherapy pill Xeloda or capecitabine that is still commonly used. If women have a BRCA mutation and their tumor is PD-L1 negative, then rather than chemotherapy, that's where we would prefer to use a PARP inhibitor. Those medicines, olaparib or talazoparib, are pills, very well tolerated, work better than chemotherapy. And so it really allows a woman to maintain high quality of life and have superior treatment without having to be hooked up to intravenous therapy, have hair loss, have all of the other complications that come with systemic traditional chemotherapy. So that is sort of the basic approach to the very first treatment patients will get in the first line setting. I'll always put a plug in for even clinical trials in that setting, because we're consistently pushing the envelope. When we find drugs that work in later line setting, we want to move them up earlier. We want to give women the opportunity to get these highly active drugs even sooner and test to see if they're better than our current standard of care. Once we get into the second line setting, so you've been on that first treatment for many months, hopefully even longer, maybe we're talking about over a year, but something has changed on a scan that warrants a change of therapy, or there's sometimes a side effect that develops that just makes a treatment no longer tolerable or safe to use, and we're at a decision about what to use next. This is a place where I would really urge, again, to be sure your doctors are looking for a mutation profile for the tumor itself. So rather than hereditary mutations, which are in every cell of the body, like BRCA1 or 2, we want the tumor itself to be sequenced and find out what genes have been mutated or turned on that might explain the biology of the cancer a little bit better. Sometimes those mutations then create a vulnerability in the cancer that we can find targeted therapies to match that would have a good clinical rationale for why a drug might be helpful in that setting. So you want to sequence the tumor to see if that helps guide next line therapy. You also want to ask your doctor to be a little bit more precise than just saying triple negative. You want to know exactly how the HER2 protein is defined. This is very important today because there are now targeted therapies to HER2, even if you don't technically have HER2 positive breast cancer. So HER2 is scored on a scale of 0 to 3. 0 is definitely negative. 3 is definitely positive. But HER2 1 or HER2 2+ are now defined as HER2 low. And if you have hormone receptor negative HER2 low breast cancer, this is now a space where there's a targeted therapy that's highly active called Enhertu or trastuzumab deruxtecan. So you want to know that biomarker, exactly what is your HER2 status, what are the other mutations in the tumor, because that will all help guide that second line standard of care treatment choice.
Okay, thank you. That was a lot. I mean, it was really helpful, but it was a lot. And I think some of the follow-up, the questions that we have, you may be repeating yourself a little bit, but just
That's
in
fine.
sections, and I think that'll be really helpful to our community. A question did come in. It's a little specific, but and I know we can't answer specific patient questions, but I don't think that her situation is necessarily that uncommon, and there might be a little guidance here. So she was an early stage ER/PR positive patient, and she unfortunately had a metastatic recurrence, and that testing showed that it was triple negative disease. So should she be considering all of the treatments in both hormone positive and triple negative disease? I suspect this is just very individualized, kind of all that additional testing you were talking of. But in general, a patient whose cancer mutates like that, what questions should they be asking?
Yeah. You're right that this is not so uncommon. We do see this in clinical practice where, oftentimes when women's primary breast cancer is hormone positive, they have likely been treated for several years with an anti-estrogen. So that those microscopic cancer cells that have been there have been under a lot of pressure to figure out a way to survive without being dependent on estrogen, right? Because that's been the approach of our endocrine therapy for so long. And so sometimes recurrences happen where the cancer no longer cares about how much estrogen is around and they lose that estrogen sensitivity. I would say we want to always develop our treatment plan based on the biology that is here and now. And so if the most recent biopsy is hormone receptor negative, then it's an opportunity to change and steer away from anti-estrogen approaches and follow more of a hormone receptor negative or triple negative paradigm. Biomarkers will matter here to check. Level of hormone receptor expression can matter. So often we get the question about what do I do when the repeat testing comes back ER 1 to 10%, technically positive, but it's low on a scale of 0 to 100. So ER 1 to 10%, we often will also treat as a triple negative breast cancer because we're getting a sign that this is just less estrogen driven, less hormonally driven.
Mm-hmm.
I would caution that there are some unique circumstances where we don't necessarily trust that the repeat biopsy is ER negative. So if folks have had that determination based on a bone biopsy as the site of biopsy, sometimes the pathology process of decalcifying bone interferes with the assay used to test the estrogen receptor. So if there is any other soft tissue location that you could get biopsied, that might be worthwhile to do to just be certain that negative isn't a false estrogen receptor negative finding.
That is the first time I have ever heard that. So that is really helpful for patients to, in that situation, to talk to their oncologist about.
Yeah.
Okay, so then going back a little bit, so to speak a little bit more about immunotherapy. So with this patient has the lack of hormone receptor targets, how does immunotherapy work for TNBC? And how do I know if I'm a candidate?
Okay, fabulous question. So let's just talk a minute about how immunotherapy works, and then we'll talk about how you know if you're a candidate for it. So the idea of immunotherapy is that we need the body's own immune system to recognize that these cancer cells are present and to help our body's immune system cells, those killer T cells, to find the cancer cells and kill them off. So the way the immune system works normally is that when the body sees something foreign, like an infection that doesn't belong, the immune system gets turned on, right? This army of cells are developed to go find that foreign thing and kill it off. But if we let that process go without any regulation, our immune system would start to attack our own healthy, normal organs, right? And that is a disease state in and of itself. That's what rheumatologists treat when you have your joints being sort of inflamed and activated by the immune system. Oftentimes, the thyroid can be involved by and attacked by the immune system. People can have autoimmune liver problems, autoimmune diarrhea. So there's a whole constellation of diseases that we're aware of that come from an overactive immune system. So the body is really smart at regulating itself. So when something foreign is recognized, the immune system gets turned on. And at the very same time it gets turned on, there are processes in place to put the brakes on it and start to slow it down so that it doesn't get overactive and cause these sort of harmful effects on normal organs. So in the cancer world, we've said, well, wouldn't it be great if the immune system could be just a little bit more active than usual? Can we help it to recognize that these cancer cells are there and don't belong? And take the foot off the brakes a little bit. Don't slow it down. Let it get really active so it does a better job at killing the cancer. So the current drug, pembrolizumab, that is FDA approved for breast cancer, does exactly that. It interferes with putting the brakes on the immune system. It gives the immune system a little bit more freedom to fight the cancer. And so the most common side effects that we see from immunotherapy are exactly those that rheumatologists face treating all the time. We can see autoimmune arthritis. We can see autoimmune hepatitis, where the liver gets inflamed. We can see autoimmune problems in the lungs, something called a pneumonitis. We can see skin rashes, all sort of from the immune system also fighting healthy organs. So that's the concept of why and how immunotherapy works in breast cancer. And it works best when it's partnered with something like chemotherapy or radiation therapy, because those drugs or techniques are killing the cancer cell. When the cancer cell gets killed, it releases all sorts of bits and pieces that help the immune system say, oh, wait a second, there's something here that doesn't belong. We need to go fight it. So just by itself, immunotherapy isn't so active, but partnering it with something else makes it really work better. How you know if you're a candidate for immunotherapy, first off, I would say these are conversations definitely have with your care team, and you can ask that very question, is immunotherapy for me? In early stage triple negative breast cancer, there is no biomarker necessary, but right now the only place for it is when a tumor is larger than 2 centimeters or lymph nodes are involved. And it gets partnered with pre-op chemotherapy, a regimen that includes Taxol, Carbo, Adriamycin, Cytoxan, all before surgery. In metastatic triple negative breast cancer, the optimal place for immunotherapy is the very first treatment a woman receives for triple negative breast cancer for their metastatic disease, partnered with chemotherapy, and only in women whose tumors test PD-L1 positive. So this is a test that needs to be done on the tumor, and a score of 10 or higher counts as PD-L1 positive. And that's about 40% of all metastatic triple negative breast cancer tests PD-L1 positive.
Okay, so a big group, a big group. Okay,
Absolutely.
so a lot of people are receiving these therapies, and in combination with chemotherapy. Because the next question that I have is how do you know if chemotherapy is working? And and what happens if it doesn't respond? And it sounds like maybe then you do a partnering agent, or I believe at the beginning when you were talking about early stage disease, that chemotherapy in TNBC is often done before surgery, so you can monitor its effectiveness.
Right. Yeah, exactly. So it's a slightly different paradigm depending on which situation we're talking about. In metastatic triple negative breast cancer, actually in any metastatic breast cancer, once we've started a therapy, we want to keep a close eye on how it's working. Sometimes we get really quick indications, like somebody feels better, right? When their cancer's under better control, symptoms can improve, right? Pain can improve. The need for pain medications can come down. That's an early indication things are working. And sometimes there are blood markers that can be an indication that the breast cancer is getting better, whether that's abnormal liver numbers start to improve, or a tumor marker like CEA or CA15-3, which is in the blood, starts to come down if it was elevated before. So that's all great news. Generally in metastatic breast cancer, about every 3 months, with triple negative, about every 3 months, we would repeat scans. And that can be either a CAT scan of the chest, abdomen, and pelvis with a bone scan to monitor response, or a PET scan, kind of a head to toe look on imaging of how the tumor is changing with respect to the scan from 3 months prior. And what we're hoping for, obviously, is that things have shrunken down or that spots that were there before have disappeared. But even if things are totally stable on a scan, that's a success, because the natural history of the breast cancer is that it would want to grow or it would want to show up in another organ. So if the therapy that you're on for metastatic breast cancer is tolerable and you're feeling okay and everything is stable and quiet on a scan, that's a win. And I would keep on that therapy and repeat a scan again in about 3 months. In early stage breast cancer, when someone has gone to upfront surgery and the tumor is removed, we call chemo after that adjuvant therapy. And there really isn't any way to monitor if that adjuvant therapy is working. There's no tumor to monitor. There's nothing to feel or see if it's changing. The cancer is out of the body, and that adjuvant chemo is really a prevention strategy. It's treating on faith in case there's something hiding out somewhere to prevent a recurrence later on. Where there's an opportunity for monitoring in early stage breast cancer is when chemo and immunotherapy are given before the surgery. And often there, you can see and feel the tumor within the breast shrinking down. Or when women have had some skin changes over the breast, redness or dimpling, you can see that improve. And many times, women over the course of those 5 months before surgery will find the breast mass has disappeared altogether. And we will often image right before surgery then with a mammogram and an MRI to help plan for surgery. And many times we see that imaging has completely normalized. Ultimately, you know how well the chemotherapy worked when you go to surgery and the pathologist looks under the microscope and will tell you whether there is any bit of invasive breast cancer remaining. With the regimen I mentioned to you, that incorporation of immunotherapy and chemo in the pre-op setting, the likelihood that everything has disappeared is about 60-something%, maybe about 65%. So odds are very much in women's favor that the breast cancer would disappear from pre-op therapy. And in contrast, for women with hormone-positive breast cancer, the tumor disappears with neoadjuvant therapy only about 20% of the time, or 25% of the time. So this is a place where triple-negative breast cancer actually performs much better in response to chemo and immunotherapy.
Okay, that's great. Yeah, that's great news. A question came in, I think is relevant here. So this patient, she's had 2 early stage TNBC. So right breast in 2018, and then it sounds like a second primary because it was at early stage in the left breast in 2021. So she's completed her treatments, including an immunotherapy. It sounds like doing fine now, but she wants to know, do you recommend any like ongoing treatment she should be on, or just any other ways that she can help herself try and reduce her risk of recurrence?
That's a fantastic question, and I'm happy to hear that you're doing so well. The first thought that comes to mind is one of the indications for hereditary genetic testing is developing a bilateral breast cancer. Also, any diagnosis of triple-negative breast cancer of any stage warrants genetic testing for BRCA1 and BRCA2. So it's an opportunity to say, make sure you have your genetic testing that can answer the question, why did this cancer develop? It can also suggest if a BRCA1 or 2 mutation is present, whether there's risk of other cancers like ovarian cancer, and screening for that would be different and intervention might be different. I would say that one of the other opportunities in this place, when you're done with all of the typical breast cancer directed therapies, would be to think about wellness and complementary approaches. So I think I mentioned a little bit earlier that postmenopausal women who receive a bone-directed therapy, zoledronic acid, have been shown to have better breast cancer survival. So this applies whether tumors are triple negative or hormone receptor positive. So I would say if you are postmenopausal, it's reasonable to get a bone density and to talk with your doctor about the role of using zoledronic acid. It is something that is in ASCO guidelines, right? That important cancer organization that I mentioned. And that zoledronic acid is given twice a year for 3 to 5 years. It helps strengthen the bones, but it also helps reduce the risk of breast cancer recurrence in bone and improve breast cancer survival. And then outside of that, there is a lot of research going on lifestyle interventions. And this is a place where I would say it's important to be cautious, evidence-based. Be sure you're checking in with your care team and your physicians about whether interventions are safe, because many people will be out there mentioning certain restrictive diets or supplements that they're recommending you take. And the evidence is really quite limited in what actually has benefit. So we do know that trying to follow a diet that is a little bit more plant-based and minimizing meat, not necessarily excluding, but just minimizing and helping to maintain a healthy body weight is going to be beneficial for breast cancer. We know that weight-bearing exercise is important. It is helpful for bone strength and cardiovascular health, but there's a big research program going on around the country looking at how a certain amount of exercise in a given week can impact breast cancer outcomes. There is a body of evidence around alcohol consumption and how that actually is somewhat toxic and can increase risk of breast cancer. So we recommend moderation and trying to stay below 5 to 7 alcoholic beverages per week on average over a lifetime. So this is another place where I would encourage exploring potential clinical trials, because although when we think about trials, we're always thinking about chemotherapy or exciting new drug development and targeted therapies, there's a huge amount of investigation out there in complementary therapies, lifestyle interventions. And if it's something you're interested in, I would say pursue it in a clinical trial so that the entire breast cancer community can learn from this. There have been trials looking at acupuncture, which actually were randomized studies that proved certain acupuncture techniques helped minimize the joint pains and arthralgias and aches that came from anti-estrogen therapies. And if that study was done with the same rigor as investigational new drugs, and that helps us go to insurance companies and say, this is an intervention that really works. You need to provide care for our patients and cover this service because we have the data to back that up. So an encouraging plug there for thinking about those non-therapeutic but interventional studies that can really advance the science and help support women with breast cancer.
Yeah, that's fantastic. I've personally heard in my own support groups and things, women really having success using some of those therapies, just to feel better, right, and to get themselves through
Right.
treatment or recover faster. And so, and I do know, I hope this becomes more and more common, but some of the bigger academic cancer centers will even have a integrative oncology center that is a part of the program, and
Right.
that is such a huge benefit because it's a really safe place to be able to explore those additional integrative therapies.
Absolutely. I would say for a minute, so I work at Memorial Sloan Kettering in New York City, and we have a huge integrative medicine group that really has funding and support to do these kinds of trials, and also maintains a website through Memorial called About Herbs that you can look up different kinds of herbs and supplements, and it will share out what the data is that we know, where there might be some concerning contraindications. And the pandemic, one of the silver linings of the pandemic was really driving digital and virtual platforms like this to offer education and deliver care and deliver services. So even if you don't necessarily have an academic center in your backyard, explore some of the bigger centers may have virtual services that you could avail yourself of.
About Herbs is so helpful. I can't tell you the number of
Yeah,
people I know that use it. It is so.
good,
I will put that in the blog post for everybody listening. When we summarize,
great.
you can have direct access, but you could just Google About Herbs and Memorial Sloan Kettering. It is
Yeah,
a phenomenal service for any
no,
supplements or other things that you're
right.
considering taking, and any indications it might
Yeah,
have the therapies that you're on, or just
yeah.
in general if it's a bad idea. Um, okay, so we are getting close to our time. So this question comes up a lot because this particular potential therapy has had a lot of news coverage lately, but it's about the vaccine. So the question is, I've heard about a vaccine
Mhm.
being developed for TNBC. Can you provide more information on its current status and how it works?
Yeah, I would be happy to. And so to just do some level setting, I just want to describe the typical three sort of phases of clinical trials, because that helps to understand what we're hoping to get out of a study when you're analyzing whether this seems like something that's right for you. So studies are categorized as phase 1, 2, or 3. A phase 1 study takes a compound, a drug, an intervention, whatever it might be, that has a really great scientific rationale and maybe some laboratory data that would suggest it has benefit. And it is the first time it is being used in people. And the goal is to really determine the right dose to use and the safety of that intervention. So oftentimes the dose is escalated in phase 1 studies, and the focus is all about safety. And sometimes phase 1 studies are done when you're combining two drugs. So you might know a whole lot about each drug when it's given by itself, but you need to understand what happens when you combine these two drugs, find the right dose. That's a phase 1 study. They are usually small in number of patients that are recruited. Sometimes they're open to any kind of tumor type, and they are usually very permissive in terms of prior lines of chemotherapy that someone may have received. But it is really impossible to make any kind of definitive determination about activity and benefit and efficacy in a phase 1 study. But you can sometimes start to get a signal if something looks encouraging, if patients actually are responding to a drug in a phase 1 trial. That gives us a hint that this may actually really work when used at the right dose. And that informs moving on to the phase 2 studies. Phase 2 trials are there to see, does this intervention have activity in a specific disease type? And there are normally parameters placed. So here you might have an exciting drug. We're going to only study it in breast cancer. We are only going to study it in triple negative breast cancer because there's a good reason that's where it's going to work. And we might even require that you have a certain biomarker, right? The tumor has to have a mutation to guide testing this particular drug because it targets that mutation. Phase 2 studies generally will have about anywhere from maybe 30 patients to 100 or so patients. So open to more women in a unique subset of disease. And that is where you start to see, does this drug really have activity? What's the response rate in the tumor? Are women living a bit longer without the breast cancer acting up? If that is positive and shows encouraging data, the gold standard next kind of trial is a phase 3 study. And a phase 3 trial is the kind of data we need to go to the FDA and say, this new drug works better than standard. So phase 3 trials are often randomized studies. We can't control which arm of the study a woman is recruited to. That's done almost like a flip of a coin by a computer. But it is taking that new investigational drug and comparing it to the existing standard of care. Those phase 3 studies are often recruiting hundreds of women, maybe thousands of women, and they're often going on around the United States and around the world. Those are really important trials to be able to get the data we need to get an FDA approval to get a drug into our patients' hands. So when you ask about vaccines, they are super interesting in concept. The idea is that we can design or engineer a vaccine just as you do to prevent getting sick from an infection, to train our own body's immune system to what the breast cancer looks like. And if microscopically anything starts to act up, our body's immune system is even better at detecting that than any blood test or any scan, and it could work to keep it under control. So that's kind of the concept of how these are all being designed, and different vaccines are engineered against different markers that are on breast cancer cells. Right now, much of the work that has been done about vaccines has been either in the lab or very early phase studies, those safety studies of injecting a vaccine and finding out what's the right dose to deliver. What are the side effects that happen when we start to manipulate the immune system? And where we have seen early exciting data is that there have been these anecdotal experiences of folks having prolonged great outcomes. So that's the kind of enthusiastic signal, what we call hypothesis generating, to drive moving those studies to the next phase. So I love when the news raises awareness about the exciting things going on in breast cancer, but have conversations with your doctor about whether you meet what some of the criteria are for these ongoing studies and vaccines. They're still pretty early.
Okay. And so am I understanding correctly that they're really just recruiting women with or maybe men with metastatic disease right now, or is it both early?
Not necessarily. Yeah, not necessarily. So there are studies looking at women, there's vaccine studies looking at women who have triple negative breast cancer and a BRCA mutation, and they have no evidence of disease, but they're studying the vaccine in that setting. There are vaccine studies looking at women who have had early stage triple negative breast cancer and are on their adjuvant immunotherapy, and they want to see if the vaccine helps that work better. And there's lots of different cohorts, and that's where I would use some of these clinical trial matching services or reach out to the investigative team leading the trial to say, am I eligible? Do I meet the criteria for consideration?
Okay, perfect. I think that current, we only have time for one last question, and I know it's been so fast, but so we've talked all about vaccines, but this patient really wanted to know your thoughts on what's most exciting in the treatment landscape. So the next 5 years or 10 years, like where are we focused on even, newer and better therapies? So what else is going on?
Yes, I'm so glad you asked that, because I did want to make sure I got in a moment to talk about this kind of treatment called an antibody drug conjugate. This is where our therapies are going. It's really fantastic drug development where an antibody, which our bodies make all the time to fight infections and to fight cancer, an antibody is designed against a target on the cancer cell. And then linked to it are a few small molecules of chemotherapy. So rather than having to give intravenous chemotherapy that goes everywhere and hits our healthy cells as well as our cancer cells, an antibody drug conjugate uses the antibody to bring the chemotherapy right to the cancer cell. So it is much more targeted. It's able to deliver a higher concentration of the chemo right to where it needs to be. And we have seen now several FDA-approved antibody drug conjugates improve overall survival for women with triple negative breast cancer. So drugs like sacituzumab or trastuzumab deruxtecan, these are FDA-approved, super exciting, and work better than chemotherapy. So there are a lot of new drugs in development like that. There are trials going on with a drug called Dato-DXd. There are studies looking at using these antibody drug conjugates earlier. So not just in metastatic disease, but since they've worked so beautifully there, start using them in high-risk early stage triple negative breast cancer so we can try to cure more women. So I think we're going to see those drugs move up, and we're going to see combinations of those drugs plus immunotherapy. And hopefully we're going to see more targeted drug development based on mutations that the tumors develop.
Okay. bright future. Bright future.
Yes. Yes.
That's awesome. Well, that is the amount of time that we have for today. So for those of you listening, if you've already asked your question and I wasn't able to get to it, we will have one of our oncology nurse practitioners follow up with you and point you to the best resources for your question. If you didn't ask a question, but you still have one, you can email us at questions@outcomesforme.com, or in the app, if you scroll down from the homepage, there's an Ask Now question box, and that will go right to our nurses as well. So please do use that. We are here for you. And Dr. Traina, just thank you so much. You have such a
Oh,
gift for explaining things in a way
sure.
that is attainable for patients. So this was incredibly
Oh,
valuable, and we know how busy you are. So just thank you for your time.
oh,
Really appreciate it.
thank you. Thank you so much for the opportunity. Really grateful. Thanks for all that you do.
Have a great rest of your day.
All right. You too. Bye bye.